Thank you. It's a privilege to be here in the very last session of the day, and I'm delighted to invite the distinguished speakers to the stage. Dr. Krishna Reddy, CEO of Access Health International, Prof. Cheng, Associate Professor of Nethersole School of Nursing, and Dr. Leekha, the Global Platform Medical Director of Amgen. And we've been sure to save the very best till last. Thank you for joining us. So as many of us know, cardiovascular disease is the leading cause of death worldwide, and it is not slowing down. When looking at the Asia-Pacific region, the impact that it's having on the lives of people is alarming, and a staggering 6 in 10 global deaths in CVD occur in the Asia-Pacific region. 19 lives are lost every minute, and in 2019 alone, over 10 million lives were lost due to CVD. So we're here today to try and unpack why this is happening and what critical measures need to be taken to bring down the death toll in our region. So Dr. Reddy, I might begin with you. High blood pressure and dietary risks are two of the biggest contributing factors to CVD. Obesity alone has become a pandemic in the Asia-Pacific region. So how can we effectively reduce risk factors such as high blood pressure and obesity?
Yeah, in terms of approach, we would like to start from the primordial prevention. That means the determinants and the lifestyles. I think a lot of discussion happened on that. The challenge is how do we actually bring that change, cultural change and the behavioral change in the way people live. That is one area I think every country has to learn from other country as to how they are able to do that. Like, for example, the Thailand as a culture, right from the population level in the rural population, if that awareness is created, so that is the second thing is the awareness of the public, how much we are investing into creating that awareness and health literacy among the population. The importance of the behavior change communication, like what type of interventions actually influence the behavior of the people in terms of their lifestyles. I mean, for example, the salt intake. This is where the influence of people, for example, a patient, experienced patient, they are best positioned to influence their fellow friends or the family members in terms of behavior change because they have gone through this, the suffering of the disease. The other mechanism of influencing the behavior has been through the, what we call as the carrot and stick principle. I mean, I think we listen to the principle of the taxation or the food labeling. So that means there is a regulatory aspect of it. So these are some of the policy interventions in terms of influencing the prevalence of hypertension, prevalence of diabetes. The second is what percentage of people are not aware that they have hypertension or they have diabetes. So if there is a systematic screening by community health volunteers, for example, in India, and now there is a population-wide screening of everybody above 30 years of age by the community health worker on a clinical step-by-step process. I mean, just measuring their blood pressure, blood sugar, and the waist circumference and the body weight, and history of smoking. Just based on these 5 risk factors, they can identify who is silently having the hypertension. So I think these are the simple interventions. First is to diagnose undiagnosed hypertension. Then they're implementing, delivering the drugs at home, just like for the tuberculosis, the DOTS principle. Somebody goes to the home and just gives the drug, the community health workers. So that ensures that the compliance with the drugs. The second element is you are diagnosed but not controlled just because you're not compliant with the drugs. So these are, I think, the interventions that have been proven, the simple interventions, especially using the community health workers and the community health volunteers, the frontline health workers, that is the most effective. I mean, even in advanced countries like in the US, if you look at the percentage of patients controlled with hypertension, is only 18%. So it is not just the literacy or the development of thing, but I think the investment into these community level interventions or the primary care interventions, they are much more effective than the other interventions. Yeah.
Thank you. And what do you think are the biggest challenges in terms of early detection in rural areas?
It's only putting an intervention in place. As long as people were not aware, I mean, just by saying that as a policy measure, on one fine day, government decides that we will screen everybody above 30 years because of a national health policy and controlling NCDs. So, I mean, within 2 years, they could screen almost 800 million people and identify undetected hypertension to a significant level. So that was, this is where how a policy intervention can actually transform the whole system.
So do you think that primary care practitioners have a role to play in implementing CVD screening guidelines?
Yeah, it is not only the primary care. I think it's an opportunity distinction. That means every opportunity to screen a patient for blood pressure or blood sugar, whether they go to a pharmacist. In fact, in the US, there was an interesting intervention because people go to barber shop. So you incentivize the barber to measure the blood pressure and the blood sugar when they come for a haircut. That was the most effective screening method of hypertension. So this is opportunistic. So even if you're a specialist, even if you're a surgeon, even if you're a gynecologist, I mean, if a patient comes with some other problem, just checking the blood pressure does not cost much. And does not. So these are called opportunistic screening methods, even not only by the clinicians or the primary care physicians, but even the allied health professionals. Somebody goes to physiotherapist, somebody goes to diet counselor, they can check it. So it does not require only primary care physician to check it.
Absolutely. And I mean, but how would you envision that we could integrate that into guidelines? Or do you think that we wouldn't need to, that we just need to look at other opportunities in terms of that opportunistic screening?
Yeah, I think more than the guideline, I would say it is more of a policy intent and policy intervention. If there is a policy intervention and if there is a national level campaign, for example, if my Prime Minister says, I will start eating millets, I will start doing yoga every day, it influences millions of people. So I think we have to adopt those, the behavioral change interventions, which are proven to be effective. I mean, in countries where they visit religious places, and those places can be used actually to educate people because they are influenced much easier by the belief systems than any other things. So we have to, I think, investigate and contextualize which intervention is going to be most effective in that country or that culture, because they're different.
Absolutely, couldn't agree with you more. Dr. Leekha, I'd like to direct the next question to you. What role do you think that the private sector can play to prevent and address CVD risk factors?
All right, so am I allowed to just say, Tanya, what you meant by saving the best for the end was actually the audience, right? They're the best audience, so thank you for staying on with us. Yes, we deeply appreciate that. So I think first and foremost for the private sector, and obviously I'm referring to the pharma and the biotech industry at length, I think our primary responsibility is to stay true to the societal expectations of having a strong, robust, successful R&D that can really drive innovation, invention, discovery, and just putting new medicines out in terms of better safety and efficacy to serve more patients. So I think that stays central to, I would say, the mission of most private companies. Having said that, I think I'm going to speak, and not mince any words over this. One of the areas and the gaps we've always had is that the importance of generating the right quality and quantity of clinical data. Okay? I will tell you about a recent publication, and this is it is a fantastic 10 years summary of data for global clinical trials, and we found that less than 10% of enrolled patients, and less than 9% of the clinical trial investigators actually came from Asia Pacific. So you've got a less than 10% representation of the trialists, and you've got a 60% disease burden sitting in Asia. It's a paradox, yeah? And something definitely needs to be done about it, because ultimately, the data that we generate needs to be reflective of local environment, not just in terms of safety, effectiveness, but also in terms of impact. So I profoundly feel that there is a gap and an opportunity for us as companies to do better and generate much more in terms of the evidence and the right amount of evidence in Asia as well. Often sponsors do post-marketing studies, real-world evidence, but it's just too late and too little. And that doesn't steer guidelines and the standards of care in the right direction. The one thing I would just say on behalf of a company, Amgen, which is what I represent, so we're a relatively younger organization in Asia Pacific. We've been there about less than 10 years. And as part of sort of our presence in the CV risk factors, particularly operating in the lipid space, we stay absolutely committed to make all possible efforts to reduce the MIs, which is myocardial infarctions and strokes, by 30% by 2030. And the way we plan to do that is with a three-pronged approach. All right, so our mantra really is, number one, we'd like to activate the importance and the awareness of risk-stratified bad cholesterol targets and the importance of rapidly achieving and maintaining those levels as per guidelines. And there was a lot of discussion about guidelines and implementation. The second piece, which is important for us, really is, igniting the urgency for regular LDL-C, or again, bad cholesterol checkups, and monitoring these high-risk atherosclerotic cardiovascular disease patients, whether they are stroke patients or heart attack patients. And the third piece for us really is, again, working with stakeholders to see how we can transform the treatment paradigm and take newer and advanced treatments to patients so that they can again achieve the lower is better approach, which is so beautifully proven through the science of literally the math is one reduces 1 millimole of LDL cholesterol and you're able to get a 22% reduction in cardiovascular events. There is nothing more impressive than that in terms of the math and how it works. In closing, the last thing I will say is I think besides the delivery of new drugs, innovations, I think we also have learned that one of our roles is our broader responsibilities to shape the ecosystem. So it's not just providing drugs, but it's also how best we're able to find solutions that are able to better the standards of care. So that's what I feel, again, we need to do in the private sector.
No, that's brilliant. And you literally just answered my next question. So I might direct the next question to Professor Cheng. In terms of innovation, how can countries leverage emerging technologies, such as wearable devices or digital health platforms for early CVD risk detection?
Okay, so thank you for the question. So first of all, I would like to ask all of you, how many of you are wearing a device that monitor your physical activities today? Yes, exactly. But I'm just wondering, the second question is whether you would like to share the findings with your family members. So the idea itself is that actually with the wearable device we can use for continuous monitoring, but not just to the patient for self-monitoring, but more importantly is whether we provide a platform that the family members can be engaged in this kind of the behavioral change. Sometimes it is difficult for, even though your wearable device have already given you an alarm that, okay, it's time for you to stand up, you have sit for such a long time, but unfortunately is that, am I able to stand up for a little bit? All right, so this is the idea as a country itself. So giving an example in Hong Kong we have the most of the 96% of the medical services provided by the hospital authority, which is under the public sector. And then in here, we've got the HA Go, which is an application. In this application, a kind of a digital health platform, the patients can review their own medical record, own investigation record, and it can be shared with the family members. Well, this is how we're using this kind of the digital platform in order to engage family in terms of the family-based kind of the risk factors management. And then the other way around is when we think about the data itself, it is indeed a kind of a big data. So one of the ideas, one of the strategies that have been will be implemented in mainland China is indeed is a kind of artificial intelligence platform, which the individuals will have the contract that they are willing to share the data with, and then it can be used for, of course, it has to be depersonalized, and for data analysis and predictive model to identify the high-risk person and give the tailored-made interventions. And last but not the least, for this ideas itself is, as mentioned earlier, even though your family members got your result, even though you got your alarming that you have certain kinds of inadequate physical activities, it's important to have someone to give you a call. So we also got, in Hong Kong, we also got the patient call services, in which the patient's data is agreed that they send out, they transfer their monitored data to the call center, and if there is any risk identified to that, then the center will call the patients. So it is, apart from individual, we also got about the family involvement as well as how the healthcare professional can intervene at an earlier stage.
Thank you very much. And, you make some really good points there. And I think, as we're looking, obviously, we know that the way that healthcare is delivered right now isn't working, and obviously with the aging population and, again, cost of living pressures and hospital wait times, I think, and again, reaching those in rural and regional areas, I think, during AFONS week a couple of weeks ago, this was really topical in terms of those wearable devices, AI, how we can utilise that, in those areas for, early diagnosis and management, so I think it's really going to be critical as we move forward. Dr. Sai, the next question for you. What role does research and innovation play in advancing cardiovascular prevention, and how can countries foster greater investment in this area?
Okay, let me attempt this one. Look, I'll tell you that I'll be the first to confess that launching a new medicine is a very humbling experience. It's a very humbling experience, okay? We know that, from data, it takes almost 17 years for any kind of evidence-based practice to actually be used in clinical practice. And I'm not talking about medicines, I'm talking about even any evidence-based practice with its lifestyle also, for it to actually be adopted by patients. And to be perfectly honest, in research we've done across some lipid-lowering drugs, with statins, with profound education, advanced lipid-lowering drugs, that number, even 17%, is a very rosy projection. So the actual numbers look very, very horrendous. Now, I say this with so much emotion because the last decade has been, if I may so, fantastic for cardiometabolic disease care. The number of new drugs we have seen to be delivered across high blood pressure, hyperlipidemia, diabetes, obesity, it's fascinating. It's fascinating because they literally have the potential to bend the curve, as was mentioned this morning, okay? But are we getting enough out of them in terms of utilization? Well, clearly the answer is no. So the point I'm here to make is there is innovation in terms of discovery, delivery of medicines, but I think what needs to also happen is tremendous acceleration of this innovation to activate healthcare delivery systems, to be able to deliver that and place these tools in the hands of patients. Okay? We've got some, again, fantastic examples of research happening around innovative areas like lipoprotein(a), obesity we mentioned earlier. Yeah? But I think the hope that I would have is that we use these really well because they will really be able to serve the end point and the KPI of reduction of that 30%, which we all hope and dream about happens in the next few years. The final point I'll just make, I think, is, again, we have learned that true and central to all this is an empowered patient. So the more we can do about patient empowerment and them being advocates for their own health, it really serves cardiovascular prevention extremely well. Okay? And that's something I think we've heard repeatedly in the room over here. So that's just one last thing. And I think maybe if there's one final point I'll make is, I think there's this leadership we spoke to in the breakthrough sessions today. And I was fascinated. So at the last ESC in London, there is the group coming together, which is the Lancet Commission, which has been appointed for Asia Pacific. It's again under the stewardship of Professor Steve Nichols in Australia and Professor Caroline Lam in Singapore. Their intent is again fantastic, completely in line with the CVD Alliance. So I think joining forces out there and creating innovative ecosystems, and I think we'll slowly and surely get there.
Absolutely. And I know we've briefly touched on this, but in terms of, what are your thoughts in terms of how AI and predictive analytics can be used to identify at-risk populations and predict CVD events before they occur?
And I've got one day to talk about this, right? Yes? Okay.
2 minutes.
So again, look, I'll make a little bit of a startling fact to you. While we all know about the major preventive risk factors, the moment you start playing with data, for coronary artery disease, there are 300, I will repeat, there are 300 risk factors that have statistically been proven to be associated with coronary artery disease, okay? So imagine how you need to bring all these together through an AI algorithm and then be predictive in terms of which patients are likely to get an event versus the others. But all in all, I think the complexity is huge. The good news is we've got phenomenal amount of data coming into our healthcare ecosystem. So it starts with the basics. It's got laboratory values, it's got high-end echocardiograph, ECGs, it's got cardiovascular imaging techniques, together with multimodal precision CAD prevention, which can happen with the polygenic risk scores as well. So you bring all these together, and we can have these risk scores as predictable risk scores. However, the problem is still brilliant at basics. So in our years of understanding patient behavior, physician behavior, we still go back to the drawing board to say, oh, but what about the basic cholesterol measurement, basic blood pressure measurement, basic diabetes measurement? And we are still not doing that enough for the masses and the populations, right? So the gap is startling. So on the one hand, we've got immense technology that can harness and tap into all the input, but the input needs to be very solid, credible, and I think we need to make sure that characterizes the longitudinal health trajectories and helps to inform better risk equations, which can eventually be used in practice. One last thing I will say is I think this whole technology piece seems to be very, let's suck it out of data from patients. But I think what we also need to show in parallel is the benefit of AI to the patient. So as was asked by my esteemed colleague over here, you've got variables, right? But are they serving a purpose in your life? You measure your blood pressure, but is that device able to give you then advice about missed medicines, better diet, better exercise, and positively reinforce healthcare behavior, which is also part of AI for me as an end result. So you've got to look at it both top-down and bottom-up.
Yeah, no, absolutely. And Dr. Reddy, how can healthcare systems collaborate with other sectors to implement comprehensive CVD prevention programs?
Yeah, I think, I mean, one of the strategy that is advocated for the CVD control is the multisectoral coordination. So the whole concept of whole of government, whole of systems, whole of society approach to the CVD control rather than a pure health system approach. Since most of these things, I mean, in fact, the 2/3 of longevity is contributed not by health systems. It is contributed by non-health system determinants. So given that fact that health is not in isolation and it has to be done, but how do we create that institutional mechanisms for that? The institutional mechanisms starting from the local governance level. So if from a village or a municipal board, if the multisectoral coordination starts from there, So that is a one strategy that is part of most of the national programs now, national action programs, that it cannot be treated just by a CVD specific program, but it has to be a multisectoral program.
Thank you. And so just in terms of, I'm just sort of shifting slightly to public awareness and education now. Several countries in the region have failed to reduce their CVD risk factor targets, with obesity, physical inactivity and unhealthy diet cited as the most common reason for failing. The diverse cultures, lifestyles and socio-economic status in Asia Pacific contributes to the added challenges towards CVD. So Professor Cheng, I'd just like to direct this question to you. How can cultural attitudes towards lifestyle, exercise, etc., be shifted to reduce CVD risk, especially in regions such as Hong Kong, China, with a high CVD prevalence?
Well, I would use three words in order to summarize how to make trying to shift the cultural attitudes. For the first one is the capacity. So whether the individual itself as well as the family have the capacity to have the abilities to know that what is to bust the myth. Okay, in terms of cultural, in terms of Chinese culture, having a children obesity is one of our consideration, right? So, but unfortunately, is that in our Chinese culture, having a fat little boy, fat little girl is a symbol of wealthiness of the family. So it's important to bust the myth. They have the ability to bust the myth and have the ability to convince their older generation, their grandpa and grandmother, because they are the ones who are going to take care of their grandchildren instead of their parents. And then the second thing, regarding to the capacity. Take for instance, because majority of our research focus on physical activities, so it's talking about practicability as well as simplicity. Because we know that we always emphasize on moderate to vigorous intensity exercise. But actually, from the client perspective, how can I achieve it? Can you give me something which is practical? I only just like we use music-paced, breathed walking, so that they can do it every day, do it in their free time, and then you know that by walking in this pace, you already achieve your moderate intensity. That's one of the ideas of simplicity and applicability to enhance that capability. All right, so the second word that I would like to use is opportunity. Because the idea itself is whether we have to enhance the family as well as the community engagement, providing an environment that which can allowing more engagement of the behavioral change or lifestyle change. And then for the last one is the motivation. For the motivation itself is think about that actually our cultural, any kind that is related to our own culture, that is healthy, related to heart health. I'm sure that none of the culture will gearing towards an unhealthy life of a person, but sometimes because of the change of our diet or because of the change of the recommendation, how we can encourage some of the heart healthy food in terms of the cultural celebration, as well as how we can use the cultural music or tradition that can use to enhance their physical activity level. So we are not convincing that this is wrong, but in other way that how can we make it better? So this is the message that I would like to bring.
Another really important point, and again, it really speaks to what we were sort of speaking about earlier about that individual care, that there's no one size that fits all, right? So what strategies have been the most effective in addressing the modifiable risk factors in CVD in the region, would you say?
Well, I would put it in two words. Okay, one is carrot, one is stick. Unfortunately, for those behavior that we don't want, for example, smoking or alcohol, the stick one, that is the negative reinforcement work, is found to be quite effective. Taking, for instance, for the tobacco, for the taxation of the tobacco use, tobacco products, as well as the banning of smoking in the public areas. So in Hong Kong, the prevalence of the smokers decreased from 9.8% to 9.4%. And then, for the other way around is the carrot, so we give positive reinforcement. So indeed, when we think about the physical activities level or when we talk about the diet and weight control, so is anchor, is somehow is anchor aligned with the presentation just now talking about financing, because we're talking about the one of the current legwork analysis regarding to the use of the economic behavioral incentive interventions. So indeed, the idea itself is a combination of the economics and psychology. People's dislike the loss more than the gain if it is having the equivalent amount. So that means if I didn't, for example, you are given $100 already. Now, if you don't perform exercise, this is just a hypothetical case, okay? All right, so hypothetically speaking, so if you are giving $100, okay, if the idea itself is you have to perform moderate intensity exercise 30 minutes per day for 5 days only, okay, then you will be, you already got it. The idea is if you didn't perform it one day, I deduct $20 from you. Instead of, after you have performing 5 days activities for $100, usually people are more adhered when they have the sense of loss rather than the sense of gain. So this is what we call behavioral incentive economies. So in terms when we take a look at this this legwork analysis, including 37 of randomized control trial, it was figured out that actually the, I need to read it, okay? My memory have some problem. I don't want to give the wrong impressions, okay? So it was found that there was an increased chance of the behavioral change ranging from 21 to 63% comparing to the standard kind of the education itself. So, and this is what also mentioned earlier is for the behavioral change, also we talk about is the practicability and the simplicity from the client's perspective. Mm-hmm.
Thank you. So, Dr. Reddy, looking ahead, given the threat of CVD, what will be the most critical areas of focus in the next decade for reducing modifiable risk factors related to CVD?
Yeah, I mean, all of us, I think, keep talking about the lifestyle changes and other things, but at the same time, in terms of the practical practical demonstration that people are really following those lifestyle changes. So that is, still it is very challenging for bringing a population level change. We talk about health literacy and other things, but the actual transformation is not happening. The ACC-AHA, I mean, they have been persisting with the nutrition, physical exercise. The obesity rate only doubled in the US, despite all that intervention. So one is we have to accept how much these things can do and how much these things cannot do it. The second, fortunately, I think as mentioned, most of the modifiable risk factors, now we have multiple therapeutic options. If I give an example of the lipid control, if you do excellent diet control, excellent exercise, the amount of reduction in the LDL cholesterol maximum is 15 to 20%. Okay. But if we have to reach the target level of LDL less than 100 or less than 70, you need typically a 60% reduction. So some of these things we have to accept that where the lifestyle fails, we should also have this provision for the innovative drugs that are there. I mean, the same thing with obesity. As long as there was no therapeutic option for the obesity, we were concentrating on the lifestyle, but it did not succeed. Not that we should give up. We should continue with those interventions, but at the same time, we should have alternative options as well. And from a policy perspective, some of these innovative molecules, then how do we make it really accessible in terms of affordability? What should be the innovative financing mechanism? What should be the pricing mechanism? What should be the licensing mechanism? I think those things also should be kept in place if we really have to target these 5-6 modifiable risk factors. Yeah.
Thank you. And Dr. Sai, what kind of interventions and innovations can be accelerated on a global scale to reduce CVD burden?
All right, the billion-dollar question. So Let me simplify this in my own mind. In my own mind, it's a bit like, let's break it down into two kinds. I think there is a piece about population health, and there's personalized health. And they both have their own place, but they're kind of complementing each other. At a population level, I have to admit that what was presented by my colleague is fantastic. I think it's ultimately down to, again, individual empowerment. It is literacy campaigns. It's patients taking charge of their lives. Now, I'm a physician by qualification, but I've been in the industry for some time. And one of the things we always do very thoughtfully is we talk about career development. Yeah? It's very easy for us to sit back and say, oh, my career lies in the hands of my line manager, and he or she is my well-wisher who will take me through all the loops and holes and get me to the CEO role. It doesn't happen. So what we tell ourselves all the time is, your career is in your hands. Your development is in your hands. And likewise for this, your health is in your hands. You need to shape it. So I think the more powerfully and the more consistently we send that message out, the more important it is. It really is up to the individual. I think in terms of the personalized healthcare, well, I would say technology has a big role to play, to be honest here. Again, my colleague spoke about Hong Kong. So, we actually worked with the Hong Kong University, and we enabled a really nice individualized tool called the P-Cardiac. It's actually a risk assessment algorithm, which is geared towards Chinese patients, and helps to really propel up their risk over a 10-year risk score and see how they qualify, not just in terms of their risk, but also what kind of management needs to go into them. And then we did a similar project in Singapore using a database called SingCloud, which is actually 5 top hospitals in Singapore and almost 17 primary healthcare setups, which actually cater to data of about 80% of the Singapore population. And all that put together is yet another algorithm, which again has been fantastic in terms of just advancing the AI piece and developing an algorithm. And I will mention again, not just for prediction of the risk, but also what kind of medication and intervention should happen in those patients. So I think again, technology has a fantastic role to play in some of the evolution of personalized healthcare.
Absolutely, thank you very much. And finally, Dr. Cheng, what is the future of cardiovascular disease prevention, and how do you envision the role of innovation, policy, and public health interventions evolving in this space?
Well, this is a very challenging question indeed. So maybe from some of the perspective is definitely talking about the personalized healthcare. Because we are talking, because of the use of the big data, because of the use of the predictive model, as well as how we can advance, we can adopt the use of the AI to provide individualized prompt or suggestions or some kind of the motivated message to change the behavior. And then, of course, it is a kind of I would use inter-stakeholder kind of the collaboration, because in the futures, when we talk about the AI itself, we definitely need to involve a lot of who are the expert who are in terms of for example, the natural language processings, in order to develop the kind of the message or the kind of the chatbot that can give a more personalized kind of the informations for them. And of course, more importantly, in terms of the policy, is how we are going to secure and share the data for better analysis and for the better interpretations for the future development. Thank you.
Thank you very much. Now, I know that we're out of time. I really want to thank the panelists for such engaging discussion, and I think it was a really nice way to finish the day. I think you've all touched on various things that we've discussed during the day, and it really speaks to again the importance of looking beyond current guidelines and how we address some of the inequities, and look beyond how healthcare is delivered today, the fact that it needs to be individualized, and really I think that we all bring something else to the table, and that collaboration is absolutely essential to reduce CVD. Now, I don't know if we've got time for any questions. Do we have time? 1 or 2? Okay, we've got time for 1 or 2 questions.
Thank you very much. Jean-Luc Isolé from World Heart Federation. I think we all agree that individual responsibility education is important. We all agree that access to treatment is essential. It has changed the way we look at cardiovascular disease. I didn't hear so much about socioeconomic determinants of health and the role of some industries in the risk factors you hide here. We all know that it's nice to train children at school, but if there's a McDonald's just in front of the door, it's not going to help them to improve their diet. Can you say a few words about, in Asia Pacific, the role of the industry, of some industries they can play in these risk factors? Thank you.
So who was it on directed to?
Yeah. Yeah, I mean, I think one of the factors I was commenting upon is the intervention at the social determinants and economic determinants, even the environmental determinants. For example, I mean, in the Asia-Pacific context, many of us don't give importance to the air quality, to the load of infectious diseases burden. We don't consider them as risk factors. We never address those as risk factors. But the air pollution actually doubles the risk, the CVD risk. And even a minor infection is not, we don't require the COVID or something like that. Even a minor infection triggers the risk of acute coronary syndrome and acute decompensated heart failure. So that means the interventions have to be on all those aspects, even the control of ordinary infections. For example, the basic preventive techniques that were educated during the COVID, we lost the opportunity to continue those measures. So that, in fact, most of my patients, to prevent these things, I have to advocate them on infection prevention more than anything else, because we consistently see most of the predisposing factor for their acute MIs and acute heart failure is a minor infection preceding that. So some of these so-called the non-traditional risk factors, I mean, or the social determinant aspect of it, as you rightly said, I think the best beginning is in the school age group in terms of how some of these things have to be inculcated from that formative age group. I think a lot of policy measures are happening in terms of whether you allow some of the processed sugar-rated drinks and other things near the schools. I think a lot of countries are trying to put regulations on that, easy access to the sugar-rated drink. Yeah, I think a lot of things, a lot of interventions can be done, not in the traditional factors, but in the school age group and other determinants. Yeah.
Thank you very much, and thank you for the question. And we've got one over here.
Thanks. Krishna from Heart Support Australia. Great way to finish off the day, and something quite passionate to me around risk factors and risk factor management. But I guess my question is, when you're looking at primary prevention in cardiovascular disease, the reality is that every single primary prevention strategy has not worked, besides the smoking, right? So diet, obesity rates are up, hypertension, since the definition change of hypertension now last year before by AHA, that's significantly up as well. Physical inactivity levels and hovering. Do you really think that we continue to bash this? And I'm a big believer of risk factor management, right? But do you think that we continue to bash this whole thing about getting people to exercise, getting people to eat healthy, all these type of things? It's very intense. You know, GPs or cardiologists need a team of individuals, of exercise professionals, dietitians, psychologists, nurses, to induce these changes, which are costly, very costly, not funded by healthcare systems. And so I guess my question is, do you actually really think that there's going to be change in the next 5 or 10 years in addressing these risk factors from primary prevention? Or do you think we should be looking at easier wins and then maybe focus on secondary prevention or, things like Ozempic? I think pretty much anyone who's obese should be on it, let's be honest. I'm not funded by Novo nor this, I'm not saying that, but, I'm in AF and risk factor management, and since those guidelines, we did that data. That's our stuff from Adelaide. There's hardly no risk factor clinics doing weight loss, trying to get people to lose weight pre-ablation, these type of things. So I'm kind of curious, do you think that there's somewhere moving forward, or we're just going to continue to talk about this in 5, 6, 7, 8, 9, 10 years' time?
I'll give it a go. So I think, and this is not going to be new for you, so obviously there is, as a company, I'll tell you how we think about this. So it is a risk continuum, right? Anybody one day before the heart attack was a primary prevention patient, right? So I think as we develop and evolve on the modalities of diagnostics, and by that obviously I'm talking about CAC scores, CT scans, to give you an example of one of the trials that we are doing, we've actually moved from a secondary prevention patient setting into what's called a relatively high-risk primary prevention setting. And there are, again, sort of algorithms that tell you if you've got a risk factor, together with disease state, together with age, together with lipids, well, there's a way, again, of siphoning that population out and getting them out. I think at the end of the day, your point is valid. It's about numbers needed to treat. And I think that falls in the realms of, again, policy and a broader piece of what's the bang for the buck that you're getting for the intervention that you really have over there. So I think, and again, I struggle with this question because at the end of the day, are we dealing with population health or individual health? So for me, every individual is really important. And therefore, I would continue to invest in primary prevention as a pharmaceutical physician. That'd be my answer.
Yeah, I might just add to that. Kristen, you know of the AF clinic that was run by the cardiac nurses, and that has worked really well. And I think this topic is really about how we look outside of how healthcare is currently delivered, right? I don't think we need the psychologists and everything else. Even, I spoke to one of the nurse practitioners not too long ago, and he said, when the patient walked in the door, I asked, how are you? And that was even a question that they often don't hear. But it's an opportunity to get to know the patient, to understand their own lifestyle and provide that individual, care plan, right? To be able to, to manage the modifiable risk factors. But that's not happening. And I think, and again, we know because the system isn't, set up to be to have those robust clinical conversations. And so I think that's what essentially we're all collectively trying to achieve here, if I'm right.
Well, I would also address one of the questions itself is currently when you take a look at all these factors, their lifestyle, but whenever we want to change lifestyle, first of all, one of the important aspects has been omitted is the mental health, mental well-being. Indeed, depression itself is going to be an independent factors that are leading to the CVD after, even though we control about the socio-demographic as well as obesity, as well as the diabetes and smoking. So the idea itself is if the next few years, so if we want to make a change in terms of their lifestyle, definitely we have to enhance their psychological resilience. And then the other things that have to be put into context is because of the air pollution and because of the climate change, the heat tolerance among our population we have to take into consideration is whether we are practicing performing the exercise in a safe context because of the heat waves, because of the hot weather. So what is next is how we are going to actually doing a kind of a safe, in performing the primary prevention in a safe context. Is another aspect that we need to take a look at it.
Thank you very much. Now, I know that we're keeping you from your break before dinner, so I'd like to thank you all and, again, the panellists for such an engaging discussion.